Hello, good evening. Today I'm going to talk about Marfan syndrome in a nutshell. I'll just go through the slides in medicine case and I'll put very short comments about each point here. Um, this slide is about Marfan syndrome, and as you can see, it's inherited in an autosomal dominant pattern. But take care, guys. This pattern is called variable penetrance, and variable penetrance means it's not 100%. If the parent has Marfan syndrome, that he will pass it to his children. And also, it's important to know that the mutation is in a gene called fibrillin 1 gene. And this fibrillin 1 gene, it's on chromosome 15. If you remember, guys, chromosome 15 was also carrying the genes for another diseases, especially Angelman syndrome and Prader-Willi syndrome. These two syndromes are very important. So he may ask you, chromosome 15 carries gene for three diseases. The first is Marfan, the second is Angelman, and the third is Prader-Willi syndrome. So let's understand why this mutation, fibrillin 1 gene, it can cause Marfan syndrome. Because fibrillin 1 gene is responsible for sequestering, or in another word, it inhibits something called tissue growth factor beta. So when this gene is mutated or is not working, tissue growth factor beta will be functioning too much, and from its name it's called tissue growth factor. So it will responsible for increasing tissue or stimulating tissue growth in various parts of the body. He may ask you about any point in this slide, and so let's go through features of Marfan syndrome. I just need to make sure that it's recording. Yes, it's recording. So features of Marfan syndrome. The first feature, which is super high yield, there is lens subluxation or lens dislocation, if you don't want to use the term subluxation. And what's important here is that lens subluxation occurs upward and temporally, so upward and outward. So Marfan looks to the moon, upward and outward, and this is very important because we need to distinguish Marfan syndrome from another metabolic disease, which is called homocystinuria. The direction of lens subluxation in homocystinuria is opposite to that in Marfan syndrome. Let's go to the next point, which is pectus abnormalities. If we examine the chest of a patient with Marfan syndrome, you may find pectus carinatum or pectus excavatum. Carinatum means that the chest looks like that of a pigeon, while excavatum, the chest is looks like a funnel, or it's directed inward. So these two abnormalities are very important also. And also patients with Marfan syndrome may have spontaneous pneumothorax, because there is unusual formation of plebs in the lung of these patients, and these plebs may rupture and it can give rise to pneumothorax. So the other point, which is super important, especially in PACES exam, these patients have joint hypermobility, and another thing which is called arachnodactyly. Arachnodactyly, it means that fingers and toes look like spider finger and toes. And also joint hypermobility. There are two tests which are very important and very simple, easy to perform. Let's have a look on them. These two tests, the first is called wrist sign and the other one is called thumb sign. And it explains itself. So the rest is the thumb overlap terminal phalanx on the fifth digit. It means that there is arachnodactyly, or the fingers are too long, and also the thumb sign, it's the same idea. So let's go to the next feature, which is tall stature. And these people with Marfan syndrome, there is something unique in them. The arm span is more than the height. So if you ask the patient to stand up and extend his arms, This is the red line here, which is A, and the height is B, the green line. You will find that A is more than B. It means the arm span is very long compared to the height, and this is something abnormal. So let's come to the big deal, which is cardiovascular complications. Unfortunately, these people with Marfan syndrome, they develop something called cystic medial degeneration. This is of the aorta. It can lead to aortic necrosis, and this is why Marfan syndrome is a fatal condition, because this aortic necrosis can lead to many other complications, such as aortic aneurysm. You see here the aorta is dilated, and this can rupture, and it can cause also aortic root dilation, and this is a form of aortic regurg. And the third point, which is the most common cause of death in people with Marfan syndrome, it's aortic dissection. So he may ask you this in your MRCP exam: what the most common cause of death in people with Marfan syndrome? It's aortic dissection. And he may ask you also why people with Marfan syndrome should have regular cardiac follow-up to rule out these complications. And there is also a valvular abnormality, which is mitral valve prolapse. So how may he ask you about this in your exam, other than the most common cause of death? He can ask you, suppose if a patient with Marfan syndrome developed a chest pain, for example, can you give the differential of chest pain in these people? I think spontaneous pneumothorax, it can cause chest pain. We have also aortic dissection, it can cause chest pain. We have also mitral valve prolapse. You know, this valve anomaly, it can cause a typical chest pain. And he may ask you also another question, for this question he can ask you, do you think people with Marfan syndrome are at high risk of thrombosis? This is false, because I think he is differentiating Marfan syndrome from homocystinuria. You know, homocystinuria, it can cause thrombosis and hypercoagulability, and this is not the case in Marfan syndrome. And the third question that he can ask you, chest auscultation of a patient with Marfan syndrome can reveal different murmurs. Yes, and we can say that the first murmur, for example, it's the murmur of aortic regurgitation, and you know that aortic regurg, it can cause diastolic murmur, early diastolic murmur, and the other murmur is mitral valve prolapse murmur, and you know that this murmur is late systolic crescendo murmur. So this will be the last point in our case today, which is about treatment of Marfan syndrome. You know, the main idea is to decrease the stress on the wall of the aorta, and this can be achieved via medications such as beta blockers. And also this is something which is considered new, losartan. Losartan, it's ARP, or angiotensin receptor blocker, which can also reduce the stress. And the other point is losartan, they found that it can decrease tissue growth factor beta. You remember, this factor is responsible for most of physical feature and also abnormalities in the aorta in people with Marfan syndrome. Thank you so much, and all the best for all of you. Bye bye.